Good afternoon, everybody. My name is Ruth McEwen, and I'm Councillor Ruth McEwen. I'm Chair of the Health and Wellbeing Board. So thank you very much for everybody attending the Health and Wellbeing Board today. Just before we start the meeting, I have an announcement which I'll read out now. I would like to inform everyone present that this meeting will be recorded and broadcast live in Microsoft Teams and will then be uploaded and available for repeat viewing on the Council's website. You should be aware that the Council is a data controller under the Data Protection Act. Data collected during a webcast will be retained in accordance with the Council's published policy. I'm afraid that due to technical limits in the Council chamber, not all the members of the board physically present will necessarily be able to be on screen on camera, but you should be able to hear everyone if they use the microphones. The seating in the public gallery will not be filmed. Members of the public are will only be able to speak if they have submitted a formal question in accordance with the Council procedure rules. Please could councillors, officers and partners attending introduce themselves before they speak at the meeting, just for the benefit of the public. And just to help me manage the meeting, if any members of the board attending online wish to speak during the meeting, please can you indicate your wish to speak by raising an electronic hand in Teams, but also verbally, e.g. Chair, may I speak? And then wait to be called. This will help us to avoid missing your request. And those members in the chamber can indicate their wish by speaking by raising a physical hand as usual. When not speaking, all online attendees should put their microphones on mute and switch off their cameras. If called to speak, please switch on your camera and unmute your microphone and pause for about 3 seconds to allow for the slight time delay in connection. Thank you very much. Thank you, Nikki. Right, okay, so on with the agenda. So agenda item 1, any declarations of interest? Nope, okay, thank you. Agenda item 2, the minutes of the meetings held on the 17th of March and on the 23rd of June 2023. Everybody attending, is everybody happy with the minutes as printed? Agreed, thank you. Agenda item 3, any questions? We don't have any questions. So agenda item 4, petitions, and we don't have any petitions. So moving on then to agenda item 5, we have the people here to speak from the Community Participatory Action Research and its report. So Rachel Spencer is here with some guests to speak about the report.
Rachel. Button there to get it going. Is this close enough?
You can bring it to you.
Can you hear me anyway? Okay, can you hear me now? Okay, fabulous. We have members of the CPAR team with us, and they're going to be presenting their research into health inequalities experienced actually during COVID, but there's lessons for all of us anyway in that. And we're going to start with Esther from the Participation Action Research team at the University of Reading.
Thank you so much, Rachel. As Rachel said, my name is Esther Enga. I'm Community Participation Action Research Fellow from University of Reading. I was a facilitator during CPAR. CPAR refers Community Participatory Action Research. This was done in 2021-2022. It was a big success because this research was done in the Southeast region. But here in Reading, it was a partnership and a collaboration of 5 partners. Reading Borough Council was one of the partners, the university, Reading Voluntary Action, Reading Community Learning Center, and ECA. So those were 5 partners, and we had 5 community researchers who did the work. They were great asset, did the work from the beginning to the end. I was a facilitator supporting them to do the research. They were looking at the impact of COVID among the PME communities, and the 5 community researchers were Eva Karanta, Hema, Donna, Krishna, and Tariq. And some of the community researchers are here today to share their research that they did and their findings and the recommendations. I'm happy just to report that from CPAR 1, Currently, we have SIPA 2 again in the Southeast because it was a great success. University of Reading is doing the training, and we're working in collaboration with NHS and Scottish Community Development Centre. I'm just happy to say as well, the community researchers have progressed from SIPA 1 and they have moved on to new jobs. And again, they're working in SIPA 2 as peer mentors. I want to say that this was a really bottom-up approach that the university is impressing, working with the communities, working with the community partners, and finding solutions together. Two of the things that made this success, made the research success is partnership, and Reading Borough Council paid for the facilitator. That was me, who was actually facilitating the research project. And I want to say that it was a big success. The second reason why it was a success is actually using community researchers from the communities themselves and working with the communities. So I just want to say that it was a big success, and this report has continued, and it has led to SIPA 2. But otherwise, I will leave the community researchers to share their experiences. Thank you.
Just before we move on to Eva, can I just see the slide? I didn't know whether it was just me.
Sorry.
Yes, that was the result. This is the report, which I think many of you have received, the SIPA 1 report with the recommendations. And then we also have the toolkit that actually we developed with the community researchers. So we have copies. Yes, thank you.
Okay. I'm Eva, one of the community researchers, and my research was on access to maternal health, especially for ethnic minority in Reading. I volunteered quite a lot during the pandemic, and I wanted to check what was the experience of women who were ethnic minority but actually English speaking, because we all know from the Embrace report, language is barrier for most of the ethnic minority people. But what about people who could understand English, were educated, what was the experience in maternal health? So that was what I was looking for, and looking at also the viewpoints of health professionals, especially the midwives. And I also looked at the impact of COVID in itself and the effect of digitization with maternity services. So in the key findings, I did find the barriers identified: women seeing different midwives at different antenatal appointments, which made them not feel listened to by the healthcare professions, and also those are costs associated with them having to access the NCP services for antenatal and postnatal classes, which made them, some of them, not go to the classes. During COVID as well, a lot of the services were accessed through digital devices, which some people did not have internet connectivity. Affordability was an issue, and some of them just didn't know how to access the devices that they had. And midwives reported their staff shortages, especially during COVID. And of course, language barriers has been a key challenge throughout being able to care for ethnic minority women. So the recommendations that I found from my research was that there was a lot of information given to women. This was in terms of leaflets, and there needed to be a better streamline of information and communication for better understanding, to ensure that the antenatal and postnatal classes were more accessible and affordable for all women, to offer more face-to-face services when appropriate and possible, and also to include digital literacy if services were going to be taken online as well. Also, from a midwife's perspective, translation and interpretation was a key element in giving their care, so that needed to be better place for them to be able to get immediate help when they needed to, and also prioritize women's health and empowering them to have individualized birth plans. Address also staff shortages, making sure the midwives are able to give consistent care, and also in places get the same midwives to be able to see the same women, which actually helps in building more trust and care with the women. And also increase diversity in senior management and provide more cultural awareness training for all staff working in maternal services. Based on my research, some very good work has been seen. The Maternal Reading Voices partnership with Royal Berkshire NHS Foundation Trust. The Inequalities Project was awarded 15,000 by the local maternity and neonatal systems, LMNS, for a 2-year project to listen and focus about getting feedback from Black, Asian women and women from ethnic minority groups, and also for the ones living in deprived areas, just to find out how much more we can actually help to improve women's lives in maternal care. And we've done a lot of this. We've worked at the Reading University as well, and we've done a couple of listening events, and which has been really, really good. I've also worked with the Reading University to do the participatory action research, and we've created a beautiful toolkit which we're now using for the CEPA2 project. And I am also a mentor for the CEPA2, and I work also with Utulivu Women's Group, which is a local charity group in Reading. Thank you.
Hi, good afternoon, everyone, and thank you the board to give us this chance to come and present you with our research finding. Last year, as everybody knows, we carried out a very beautiful research during COVID, and I have been appointed from the organization to look at the men and mental health and the impact of the mental health during COVID and lockdown. And it was a very interesting research for me to find what I was going through as well. And the research focused mainly on men from Black and ethnic minority background. And we produced questionnaires, and we did the research and analysis. We came up with a good findings and barriers. And no doubt that COVID has affected a lot of people during the lockdown. And from the research showed that a lot of men are financially and mentally and psychologically being affected during COVID. And there's a lot of barriers which men from Black and Asian ethnic backgrounds are having barriers to access these mental health services. So we listed some of them because of the time. I'll just go through some of them. One of the main issues we found in our research is the language barriers and the translation, which is preventing a lot of people to access mental health, because to tell what you go through, and most of the services are through online services. So translation and language barriers have been very difficult, and difficulties of referrals and long appointments. A lot of people experience that, and I'm one of the people who noticed that when I'm dealing with my cousin who goes through a lot of mental health, and to get a mental health appointment is a nightmare. 6, 7, 8 months, and sometimes the referral from the GP to the mental health services is a big issue. Now, lack of the knowledge of a lot of people from ethnic minority backgrounds of how to access mental health services, because they don't know the system, they don't know how to access it and where and how. So that's one of the issues they're facing. And one of the things that they experience, the institutional racism, that they think men and from ethnic minority backgrounds, they think that because of their color have been subjected to a lot of racism when they try to access mental health services. And the cultural stigma which follows men, when it comes to the mental health, it's an issue nobody want to talk about it. When it comes to men, alpha male always dominated men not to talk about it. But when it comes to men from Black and ethnic minority background, it's going to be twice as hard, because it is like a taboo. Nobody want to talk about it because it's a cultural thing. nobody want to be weak. Men never cries. So that barrier as well block a lot of men from seeking mental health. And mental health is one of the issues. If you don't catch it and treat it early, it will be a nightmare. And through all our findings, me and our participants, we try to put some recommendations, too many recommendations, but we try to summarize them. At least it can get some attention. So when it comes to the recommendation we put is funding. Funding is one of the issues affecting a lot of things. So we wish if the government increased the fund for mental health services to make it more affordable to people, and also ensuring the mental health issues are identified early, because mental health, if you catch it early and treat it, it will be easier and cheaper. But if we let it progress and it's become a big issue, it's very difficult to tackle. And we know we have a lot of examples of what the result come out of people ignoring symptoms of mental health. So some of them we have from my community who get agitated and their mental health being ignored, and they end up stabbing and killing people in Glasgow. And there's a lot of examples like that around the country. So we wish that it's get identified very early, tackled and treated. It will be cheaper and easier as well. Recognize and support the role of voluntary action, voluntary and community organizations. And from here, I can thank Otalivo and ECA, because the organization work for, they stepped straight away and put this recommendation ahead by creating a Tuesday hub for tea and coffee. And we have a wonderful James Momo from British Health, BFCT, he who comes every Tuesday to deliver sessions for mental health and stress and depressions. And because we have a lot of refugees coming from war zones around Reading, and they are in hotels in Reading, everybody aware of that. We have a lot of people from the community, they seek help. So we have that wonderful hub. And also Otolivo, they have the Thursday conversation talking about well-being, and it's a very good effort. So we wish if the government recognizes voluntary roles and increase the funding for them and open more hubs for people to turn up and talk about their issues. Promote mental health awareness in colleges, schools, and universities, which is it's a good idea to allow people to talk about what they go through. So that will make people know their mental health status and help them earlier. So schools, we know a lot of people have been through school, especially children at local primary schools. My son is subject to a lot of bullies. So unless we tackle that and let it progress into their later stage of life, is going to be an issue for them. Develop conversation hubs and offer professional support, and also training the mental health professionals, because misdiagnostic of mental health and ignoring them sometimes is an issue, because some mental professionals sometimes either intentionally or unintentionally they escape or they don't recognize symptoms of mental health. So if they better trained and to pick up these issues, it will be easier when it is in early stages. Support of members of the community who conduct we will come back to this because community research, who are the best people who are in and within the community, identify this type of issues. So community researchers are get trusted with the community. Myself, I was so worried to carry this research and to talk about it. But when I found other people's problem, my problem is became a very small within their problem, because I found a lot of people, they have a big problems, bigger than mine, and they are not talking. But they talk to me because they said, you gave us a chance to talk, and because you talked, we are going to talk. So that's why I found out what they are going through, and I wish if they encourage these people to talk about. And the wonderful CEPA is allow us to develop, as my colleague Eva said, the toolkit. That's our experience of going through the CEPA research journey, and we documented our journey in this book to be a guide to oncoming CEPA researchers, because we documented every single journey we did, and the key finding and recommendation is like stage 6 and 8 in our research, and it's going to be a good guide for the people who are taking this research further on and on. And as Eva said, we are lucky that we are working with CEPA 2 and CEPA 3, CEPA 2 with Reading University to train the CEPA researchers using the toolkit we developed, and it is a wonderful thing. So because of that, I can, in personal stage, I got a job from Health Watch, because Health Watch is one of the bodies that seeking change, and I did the research. I don't want to waste it, so I got into Health Watch, Reading and Wokingham, and there's a lot of questions I have been asked by my team leader, and a lot of people, they ask me every time, and this question is following me all the time, and I can't find an answer for it, which is what happened to the research you have done. So I wish if I can get an answer today, because these people who participated are still waiting to find out. And we are training CEPA 2, and we are talking about contract for CEPA 3, and we don't know what happened to CEPA 1. So I wish if I can get an answer today to at least to assure them. Otherwise, it's no point for doing research, training researchers and doing research, and we don't have a result for what happened first. And I wish we'll come out with a very good talking today, and thank you very much.
Thank you, Tariq. Krishna, do you want to?
Good afternoon, and thank you very much for giving us this opportunity to share with you all the impact of COVID-19 in local communities, mainly BAME community, but my research was focused more on mainly Nepalese communities living in East and South Reading. Why I selected two areas, I think more poverty index are in the South Reading, I heard in the report also somewhere I found this in the report, and in East Reading quite a mixed community living and a bit, highly dense populations living in Reading. That's why I pick up these two areas. Actually, this before we just initiated conducting the research, we receive sufficient training from experienced trainers, and all these things I think really prepare us to start research work. The title of my research, as you see there on the screen, to explore it's a 9 months research, and just to explore the country, explore the impact of COVID-19 in Reading Nepalese community groups. So during this research study, I employed 3 different tools that is commonly used for this study. One, we conducted a short survey also, so that we'll just it will help us to enrich the information, and similarly we had a focus group also we discussed thoroughly. And we had cross questions, who agrees on that and who not, and why. We are trying to get their opinions. And the third one is the in-depth interviews. We just try to represent age group, sex, and different occupational groups and all other variables. So we try to incorporate so that everyone's voice will represent on these findings. So based on that, we actually the people, they could not really speak the second language, we call it English, and we had to talk first with them in Nepali, and interpretation, everything, and we had to transcribe all the Nepali, the information that we collected, gather, and we had to transcribe into English. So it was not that easy job. Actually, I experienced was a tough time, though we work hard so that we'll come up with some good things for the betterment of the communities. On that way, we done this study, and as you see the key findings, we just classify, categorize mainly the key issues based on their information that we receive. One was the living conditions. So what I see based on the interviews that we held with them, that most of the community members, they used to live in the share households. More than one family, they live in the same household. It means all age groups are living in the same household. Means that some members in that household go to work. Some work with the hospital, some work a different nature of work, and they come and go. So there are chances of getting symptoms of COVID-19. And also what they mentioned during the interview time, that mainly vulnerable families, single parents, family with children, and people, those who could not really speak language and could not really grasp the information that is flown through the media or whatever. They received the information was quite confusing for them, and they just that also somehow they mentioned this disproportionate impact they felt, that they were really much worried, suffering. And similarly, as I mentioned earlier, communications. There was a bit, the communication, reliable information they were supposed to receive on time. They said it was too hard for them to receive a reliable information from the reliable source. So they had to depend on somebody's, the support, that they could not really, come up with the complete information about the COVID-19. So, as earlier friends, they mentioned that there is a internet, the limitation, being a limitation in English, definitely they could not really, use the internet services. So they could not really access those reliable information. Also, they were supposed to, depend fully on others' information. So that also created somehow fear or and on trust on the information that what they were receiving. Similarly, I think regarding the fairness, what they mentioned, or the trust and vaccine hesitancy. As I mentioned earlier, what they sometimes heard, they mentioned that in hospitals, doctors are dying, some teachers are dying. Even they heard that whether this was a rumor or the fact. Some of the hospital staff running away, jumping out through the, the barriers, something like that. So that sort of message they receive, and it was such a, very terrible situation they mentioned. And also while they go for shopping near the groceries, and there was nothing available what they were after. Like for instance, their Usually they eat some pulses, rice, some ghee, some things over there. So that is also impacted, for them. So this way, I think, and what they have also mentioned that in a family, some of the members, they have to go to work because they have to pay utility bills, they have to pay mortgage, they have to pay daily expenses, everything. And the guy who can speak English a bit and can help to their family members cannot stay at home. He had to go to work. So they could not communicate and just the booking with the GP that, all these things, it was really horrible. They can do. So looking all this, the scenarios, I think we can guess how was the situation of these people. So that's why it was really disproportionately impacted in most of the families living in Reading. So based on that, I think they have given some thing what we could do better in future, or just change the service style, or improve the services that we have been rendering so far. And I think one of the recommendations that we have put here is outreach and engagement services. I think currently I'm working with this British Science Association research work. I think we have been using that approach. So this is quite, I think this is quite effective also, I feel. So I think this is one of the recommendations we have made here. Probably we have to go to the root, go to the communities and really have some interactions and make them feel a bit happy and safe. Though we have to give not only medical treatment, but we have to give some psychological treatment they are looking after. If we go and talk about medical words, we can't explain that things, and we are not the right person to do so. So if a medical person speaks with them, they trust on that, and they just follow what the medical person they talk about. So this is the thing they are expecting. That's why we put this as a recommendation part. And as I think based on all this information, what we gather, there are the language barrier, there was a cultural things. I think language barrier, there are, we have to split in different stages and different forms of barriers. Not only they can't speak English, but even if we can speak a little bit English, the medical English we can learn, we can understand well. So we have to, classify, or we have to cluster this, and we have to deal on those issues separately, so that I think we can reach to people's real issues to address in. And there are some other religious thing, cultural thing, all these things, because most of the Nepalese community, they trust on a traditional way of treatment. First maybe they just invite somebody who does this blah blah things, and herbs. They use different types of turmeric and things like that, and they use all those things, and only after it doesn't work, and they just go to next available services. That's the way they do. So sometimes there is a big misunderstanding. They mention that this COVID-19 is like a flu. This is not that critical virus that really impact negatively. Yeah, that way they're just staying at home. They didn't really try to get quick services also. And sometimes they heard that if we have a vaccine, COVID-19 vaccine, maybe the women, those who like to have children, cannot get conception and will not get a child. So there was, sort of things they expressed during this interview time. So I think overall, we know all the situation of Nepalese community in Reading. Everyone, I think, either directly or indirectly, we have been happened with them and talking with them and reported maybe here in a different means of things. So I think we know this all, and personally, I am quite enthusiastic and optimistic here being with you all that something will happen. If we recommended something, we will get soon something action, so that those whom we made an interview, they keep asking us, where is your report? What do you do with this report? What's the meaning of this thing, all these things? They keep asking me. So, time? Yeah, okay, sorry, time already gone. So overall, I'm still hopeful that we will get something for them, for the betterment of their life, everything. But this is an incomplete thing. Maybe I share with you. Complete is here. Unless you go through this all, maybe it will make some confusion for you. Thank you very much.
And thank you very much to Eva and Krishna and Tarek and Esther as well. And I would like to just highlight on the report page 4, we have the recommendations. So please do take a look at those recommendations, and to highlight on there as well the work of the Reading Community Learning Centre. And to Donna and Hemelina who aren't here today, but there's a complete set of recommendations there, and I'd really appreciate you taking the time to have a look at those. I think it, as Esther said at the beginning, very much partnership work, with thanks to the public health team here at RBC, in particular Dana. And its ingredients, it's the voluntary sector. We're so lucky in Reading to have the University of Reading, to have the richness of the voluntary sector that we have, and the researchers and their enthusiasm. But behind all of this work, creating these beautiful reports and these recommendations and the support that's been given to the team, are hundreds of people in the community that have engaged with the researchers and shared their experience and given freely of their time. It's not their work, but they care passionately about their communities, and they want to see something different, and they want to see a change, and they have, shared their heart and what was a challenging time for everybody, but some worse than for others. So thank you very much for your time, and please do take a look at the recommendations. Thank you.
Thank you very much for that presentation. I'd just like to say obviously thank you, Rachel, but thank you to Esther, Eva, Krishna and Tarek. It's, when we receive reports, always very interesting, but to actually hear from the participants that people have developed the report is so, it kind of brings it to life, and it's really, really useful. So thank you very much. Thank you for coming in today. I really like the recommended actions. I've been reading through them, and I won't go through all of them now because you've highlighted where they are, but just really incredibly useful, and highlights the importance of partnership working, as you've raised. But I was going to open it up to other questions. I was going to ask about another, kind of future reports, but that was raised quite quickly about the CP2 report, which is on the way. But I was going to open this up to questions, and I can see Councillor. Oh, sorry. If we go to Martin, that's fine.
Sorry.
Yeah, thank you. Martin?
Are you coming to me?
Oh, sorry. I thought you were indicating. Sorry.
I am. Yeah.
Yeah.
I think it's an opportunity to respond. I'm Martin White, consultant in public health at Reading Borough Council. I have the happiness of working with Dana, who's in our team and has worked and contributed to this report. I'm delighted that we've got it to the top of the agenda finally for the Health and Wellbeing Board. And I was messaging Melissa just now on the back channel. It feels like we've got oxygen in the room at the Health and Wellbeing Board. So the first thing to say is thank you for that insightful and compassionate and rich report. I want to pay tribute to those people that you referred to that made such a massive contribution to getting us through the COVID pandemic. Everybody within the communities, and within the public services, some of them paying a very high price and cost indeed. And I had that experience as well, actually, Krishna, watching people running away when really they would have been better to have stayed in place and played their part. At the heart of this is the opportunity to talk about health inequalities in our city of sanctuary. And I hope you feel encouraged that there is a real commitment, certainly from the team that I work in, the Public Health and Wellbeing team, and our colleagues in adult social care, and the colleagues that I've met and worked with over the last 9 months across Reading Borough Council. There is a real commitment to influencing and shaping the way that public services work with communities. And the emphasis there is on with communities. We have professional training, skills and knowledge that we need to put at the disposal of communities to make it come alive and into action so that we can all move forward together. And we'll work to do that to make sure that our colleagues across the integrated care system are joining with us, because we've all got to learn in this, no matter which part of the integrated care system we're working in. I'm just going to briefly, if I may, just take up a bit more of the oxygen in the room. And well, I'm online, I know that, but just to say a little bit about how we're responding to those recommendations. There's a lot there. They're really valuable, and I encourage everybody to dip into those and have a good read. But we are working hard to improve the availability and quality of the interpretation and translation, certainly of the services and the work that we provide with Compass Recovery College, and with our work with the asylum and refugee communities in Reading, to make sure they've got the information they need to plug into services and get the need and support that they badly need. We're working also to improve cultural awareness and training. We've got a wonderful programme called The Big Conversation that's starting in the authority, led by our colleagues in workforce development, about equality, diversity and inclusion. That just skims over the surface of what we've started to talk about, teachable moments, to uncover how it is that we work with communities. We don't want to unwittingly contribute to excluding anybody and widening the gap in inequality. We recognise the importance of the voluntary and community sector, and I hope, Rachel, you'll endorse me when I say this, that we are working with you and with our colleagues in ACRE. It's a very fruitful and strong relationship with a high level of trust, and I hope colleagues from Health Watch will endorse me in that as well. We understand the importance of face-to-face appointments and consultations, and I apologise I can't be with you there today. We're working, as I say, with ACRE to deliver culturally tailored mental health awareness training. We're breathing life and money into our Community Health Champions network, which was developed in response to the COVID pandemic, and they are embedded in the communities around Reading that you've been reporting back from. So I'll leave it there, if I may, Councillor McEwen, and hope that gives you some confidence that we will build on this. We look forward to the next stages of CPR, and we're ready to learn the lessons of working and doing the research with communities. Thank you.
Thank you, Martin. Councillor Gittings?
Yeah, thanks. It's Paul Gittings, Curly Ward Council and Lead Council for Adult Social Care. I mean, first of all, like Martin has said, I'd like to thank you all for your presentation, which I found informative, but also in its own way kind of heartbreaking, actually, if you read some of the accounts. And I think that the thing that shines through is three words: communication, 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 and in many cases the lack of it. And some of that lack of communication, I'm going to say this, started from the very top. At the moment, there's a COVID-19 inquiry. It's taking 3 years, which seems to me an extra long amount of time for an inquiry. And it also appeared to me actually that groups like yourselves should actually be giving evidence to that inquiry. So I don't know if any thought's been given to that. It's probably kind of my sort of question, because you've done a lot of really quantitative research here, and I think that's useful. I'm sure it might be happening in other areas, but in Reading we've done it. I think we should be proud, and I'm glad to say that Martin is saying that we are, enacting, on it in a positive way. And to be absolutely honest, most of the recommendations around community action, they could apply just to your communities, but actually to all communities in Reading, because this is about community engagement, because without that, there is a lack of communication and understanding. And, you know, it really, the treatment that people receive should be about what matters to them, not what actually matters to medical professionals. So I was, you know, the lady that in the maternity section, countless, she wanted to give birth in a certain way, she wasn't listened to. Now, there may have been a medical reason for that, but I suspect there wasn't. It was probably people think they kind of know best. And also, the poor lady that was in the hospital and didn't want the hospital food, but, you know, to her own right, and then sadly died. So I'm afraid that ethnic minority communities, due to, I have to say, to government failings, actually, in the messaging at the very start, were at the sharp end. So a lot of the early messaging, if you remember, was around washing your hands and those type of issues, whereas actually this is an airborne disease, and people in front-facing jobs, which obviously include a lot of people at the sharp end, you're the heroes of the pandemic. People working in hospitals, bus drivers, people, you know, delivering, all those type of jobs. Well, obviously, sadly, the death toll was higher. So if nothing else, we can learn from that if we have another pandemic. But actually, I think the lessons are more wide-reaching than that. We've had the pandemic. We now can understand some of the issues that are really brought into sharp focus by these accounts. And these accounts actually could just as easily be happening without COVID, to be honest, wouldn't it, really? And as I say, I think it is about, I'm going to use the word co-production, people working with you, getting your views, taking them on board. This is replies in my portfolio now of adult social care, in mental health services and all public health services, is actually listen to people, and then actually we might get somewhere. So sorry to sound off, I actually feel very strongly about this, and and it's really great you've come today to share these accounts. And as I say, I hope you can share them. I'm looking at Rachel, share them a little more widely as well, because it's a really great piece of work.
Sarah Webster.
Thank you. Hi, I'm Sarah. I'm the Berkshire West Director from the Integrated Care Board, which in a nutshell is the NHS Commissioner. So I agree with comments about there's some really stark examples in here, but I was reading the recommendations with great interest because at the moment, a number of us around this room, so John, myself, Andy, Melissa, Alice and Rachel are all in discussions about a service, a kind of a community wellness outreach service, which is taking physical mental health checks plus other services right out into the heart of our communities where they're most needed. It's at a very early stage of thinking, but I think that's a route to a lot of these recommendations can inform the way that is developing going forward. So we need to think about how we link directly with you in terms of as we shape that up further. But also some of the comments here around training for staff. We're, again, in early conversations with the University of Reading about what the training package is that we offer to some of these community outreach workers that hopefully are individuals from the heart of our communities, so not us enforcing ourselves upon the communities. So how we build in some of these training aspects into that training package as a starting point for taking some of this forward. So echo comments about thank you very much for all the work that went into this. We're very much have a route to start taking some action on the basis of this report, because I appreciate how frustrating it can be when all of this work goes into something and then there's no obvious route of how we're taking things forward. So thank you very much.
Thank you, Sarah. And I think John is online. John Ashton.
Hi, thanks, Chair. Oh, a bit echoey. So yes, just to build on that and what Councillor Gissing was saying and Martin was saying, this is a really important base to build on, and the links with the university I think are really important. I think we have to look forward now after the pandemic and see what the lessons are and what the building blocks are for the future. And I just wanted to really draw attention to the fact that the literature and the research on migrants in different parts of the world is that first generation often do comparatively well. They bring with them cultural assets and gifts from wherever they've come from, but very often they're not recognised and received and supported and built on. And what's ironic is that very often the next generation, their health deteriorates in the second generation. And, you know, we really need to see how we can better recognise the gifts and assets of new British and get alongside them and enable them to maintain cultural practices which are important to their well-being, whether that's to do with food or spiritual aspects or the social life of communities. But there's a lot in there to do. I'm afraid the host or community into which new British come is often very disparaging of the things that people bring with them and doesn't realize just what's there to be supported and built on. And I mean, an example I will give you is the one I saw some years ago in Toronto, where Caribbean islanders from the different island groups were in quite large numbers in the Toronto area, Greater Toronto. But they often came from villages and they were accustomed to growing their own produce, their own vegetables, keeping their own chickens and stuff like that. And they set up community gardens for the different island groups, enabled them to continue with their horticultural practices in an urban environment. And what I saw there was the different island groups took it in turns to host events with the food from the different island groups and so on. And this became a very important focus for social cohesion. So I think we need to really move into a different way of looking at newcomers and see how best we can build on the assets and skills they've got and avoid the trap of their children and the next generation experiencing worse health and well-being than they often do themselves, paradoxically.
Thank you, John. Do we have anybody else want to speak on the report? No. Okay. Well, you know, again, thank you so much for coming in. I think, as everybody's raised, it's really important work, and let's hope, you know, this will be continued, and hopefully be able to come back and do some more talk about CPT and the work that's carried on. So thank you very much for coming in. Yeah, you're welcome to stay. Yeah, you're welcome to stay. Okay, so moving on then to agenda item 6, we have the Health Watch Reading Annual Report 2022-23, which will be presented by Alice Kunjapi-Clifton. Thank you, Alice.
Good afternoon, everyone. Can you all hear me? Yeah. The whole objective of this is I don't have a slides at the moment, so I'm going to be talking. I'm hoping that everyone's read the report, because you know that will show that what work we've done. But I do encourage you all to read the report, because it is about our activities for the whole year, especially being a new organization taking over after a previous organization that's run for 10 years. It has been a challenge, but I would say we have got a lot to celebrate about. Even though we are a new organization, we've started running from ground onwards. And so as I mentioned, the advocacy people took over in June 2022, and then we started advertising for staff and volunteers. So I came on board as the lead officer in October, and then we've been working since then, staff, and then reaching out to the community to get feedback and things like that. So a lot of that, but we've also championed. I have been visible in many meetings and sharing the role of Health Watch as being a critical friend, but also holding services to account, which I think Sarah knows very well. But the whole idea is, even though we are a critical friend, we want to work in partnership, because I do not think that, criticizing organizations is the right thing, but also, working together and having the voice of the community heard is very important. So this is what our aim is. So what we have done since we come on board is, as I said, laying the foundation. We've championed the asylum seekers experience. So we have, shared what they've been going through to the stage whereby Reading Borough Council has embraced it, especially public health and housing. And also what has also happened is the Bob ICB has now got the asylum seekers as an agenda for their health inequalities, which I'm going to be presenting on the 27th of this month about the experience of the asylum seekers. So it shows that the voice of the vulnerable are heard. The other thing that we also championed is the maternal mental health. So Health Watch England championed, did a campaign about what is the experience of women at 6 weeks postnatal, and then they found out that women at 6 weeks postnatal checks, the mental health was not a conversation, it was a tick box. So we will be championing that going forward, of how to see how the 6 weeks postnatal check is done. So we are talking with maternity and as well as the GP organizations to see whether that will, how do we make this better. So during, on top of coming on to a new organization coming and taking over the Health Watch in Reading, we also were part of the new integrated care system, because that happened in July. So we had to learn how to be part of that as well. So that has been another role that's been very involving. So we've been part of the transformation of continuing health as well. So we've had that voice there as well. And also, I would encourage you all to just read the report, but what I would like to do going forward from this report, our next step, Nikki, can we show the slides, please? So what this slide is a proposal that we are going to take forward. So, I mean, that's fine. Go down, keep it going down. People know who we are. So this is going to be our work plan, a proposed work plan for 2023, which is looking at, so what we did was in April, we put out a survey to the public to ask them what is the important priorities for them for health and social care. And this was the topic that came out. So GP access and quality was 64%. Then dental was the other next one. So I think, Chair, you did ask about dental the last time. So this is what we are looking at. We'll be looking at young people, because under 10, because one of the things that has come out is young people have had to have extraction of their teeth under general anesthetic. So we're just going to see that. And this is going to be part of the Core 22+5 project. So we've received funding from NHS England to do this, so going forward. But we also want to look at experiences of women about dental care, because they are entitled to exemption for dentistry, but apparently they're not getting it. The other one is also learning disabilities, the other one, which was shared with me again at the care strategy. So asylum seekers are still the top, also part of our work plan. But the other thing that I'm like what has been shared today about the language, the previous Health Watch did a project on accessible information standards about the lost voice. We will champion that as well, to look at what is available at the moment, to just doing mapping of what services are around. Are interpreters really in the GP services? What are they using? So accessible information standard is going to be one of the priorities in our work plan. Next slide, please. And then on our watch list, the maternal mental health is going to be on part of our watch list. Building Berkshire together is still the same because that project is still ongoing. Continuing healthcare is still ongoing. Cost of living is also one of the things that we found out that people are not taking, are able to get prescriptions and also transport to appointments. So we are going to watch and see how much of an impact it is. Support for carers, especially hidden carers. Why carers are not coming forward to getting support. Mental health support for children and young people is also still on the agenda as well. And our local Bob ICP health inequality priorities, because it's going forward, and how we as HealthWatch can help. And one of the things I'm very, very keen on in all my messaging, all my conversations is communication is key. And how it's presented is also, in different languages, and easy read as well. Next slide, please. Okay, thank you. Any questions?
Thank you, Alice. Really welcome report. It's a very positive report. It's really good to hear about all the work that's happening. I really like all the, the information detailed on the report around the asylum seekers. I mean, the work you've done there around raising the safeguarding, which is really important.
Yeah.
So, it's really informative. It's very interesting as well about the emerging themes, and you're talking about dentistry, which I know we've sort of mentioned as well, which is becoming more and more of an issue and a concern amongst lots of other things for residents in Reading. And I was going to ask you about, in terms of the board and the support that, more support that you need from the board, or anything we can do to help progress.
I think increasing
the goals and
awareness
themes.
about HealthWatch is one of the things that people don't realize, that our statutory powers, and also it's like, what's the next step, what Tariq was saying, because when I got the CIPA report and I was looking at it and say, so where you're taking this, and what the encouragement would be is share with us, and then we can help bridge the gap, and that's the thing that is my encouragement, suggestion to the university and everybody, share with us conversations so that we can help you all to break the barriers. But one of the things that we are very, very dependent on is volunteers, and so that has been a challenge for us. We've not been able to get, but so my team, like Tariq is part-time, but he does amazing work. But we really, really need support in that way to get make us more visible, because I've been doing a lot of road shows in a big, and our team has been visible. They've been going and connecting with the community centers and groups, but being small, our remit is quite large, but we have to be strategic in what we do. So it's not that we're not we're not keen to look at certain topics. Come and have a conversation with us and see whether we can help people. Sorry, before I forget, Andy, just to share that regarding the GP access, I'm having a conversation with Amit, with your alliance, to see whether we can work together so that we don't have this, because my perception is there is a barrier here that public is not aware of, the changes and things. So I've encouraged Amit to have a conversation with us, because he saw our report and said, can we come together? And so that's going to be happening too.
Thank you, Alice. Melissa?
Sorry, Melissa.
Thank you, Chair. I'm Melissa Wise. I'm the Interim Exec Director for Adult Social Care and Health here at the Council. I just wanted to say, Alice, thank you hugely for your report. It really demonstrates the journey that you've gone on as HealthWatch coming into Reading for this year, and for championing some of those really challenging agendas that are shared agendas that we all really care about. And that's really important. I've also really valued the partnership, and your point earlier about at that kind of challenge, that critical challenge, which is really important, but you've delivered that in a real partnership way. The agendas for going forward, I think we would all recognise. You've just talked about GP access, dentistry. So again, I think that they're absolutely on point. My question was there anything else for Reading through all of your conversations that's emerging that is helpful for us to just have on our radar that you can't pick up because clearly you can't do everything?
I think one of the things that maternity is a big thing, especially ethnic minorities. And when we know the Embrace report has shown that, so that is one of the things that we should not only depend on the NHS alone. We should be doing more work, collaborative work to make that voice heard, kind of thing, because there is a cultural. I'm so happy to hear what Martin was talking, because we've been talking about cultural awareness, because cultural awareness is important, because there is this perception when you're in Rome, do as the Romans do, but it cannot be that way. We have to embrace heritage and culture, because we were brought up. I'm a first generation migrant, and there are things that I have brought with me, and I don't want to lose them. And and that's the thing. And I don't think I don't want my children to lose them either. So I think there is work done about cultural community, but also understanding that I struggle with the language seldom heard, hard to reach. They're not. Let the system be the other way. It's the system going. So going out to the communities is the best way. I champion the Meet Pete team for going out there. So that's a simple and a model that we should be using, because I do think there is something in that, in the sense that, but one of my things about the Meet People is capacity, because workforce, but also having more people to be able to speak the language or to be able to translate. And I'm very keen. The other thing, Chair, if you allow me to say, I'm very keen to work with the community champions, because I think having a dual identity with Healthwatch will make a big difference, because they are there with the community, helping the community to share the voice, and why not share with us the information? That is the one thing that I'm very, very keen on. But also the fact that the volunteer sector, they've done so much work, sometimes you feel that the volunteer sectors are not coming forward is because their voice, they've already shared it before and it's not been heard. And this is where Healthwatch can help. And I think that's where I quite like to champion.
Thanks, Alice. And I think John is online.
I just wanted to underline that issue, particularly about maternity. I had the unfortunate experience in a previous work I was doing where we had 3 maternal deaths in 2 years, and which is very exceptional nowadays. Nationally, there's probably about 40 or 50 maternal deaths a year, and to have 3 in one relatively small district is quite exceptional. And people don't ask the question about what's going on here in terms of whether there's services are being appropriately provided culturally, and they tend to interpret that kind of situation as being people somehow being stubborn or difficult or not taking advantage of the services that are there, rather than thinking about how to provide the services in a more culturally appropriate way. And so I think that's a really big one, particularly for women and children, which is the traditional entry point in a lot of the development of public health services, is maternal and child health at that very beginning of life. So I think we do need a spotlight on that to get it right.
Can I respond? And I do agree with that, but the other thing is also when you look at maternal, if you get the mother, you get the child, you get the father kind of thing. So I do think this is something that I think needs to be looked at in a big base, because it's an impact on a whole family, isn't it? But I do think we should champion that more than anything else. But also I don't want to dismiss what Krishna and Tariq has said, because mental health is a big thing, and also the barriers for mental, discussing about mental health, the language that we use also matters. And I know, and that is one of the things, because not all of us understand the language of medical terminologies. And also, the other thing that tends to happen is also we assume that they understand that language. And I think we need to check ourselves whether they do. Because if you ever hear me say, I say, does that make sense? It's not because it's because sometimes people don't understand me. And so I always check myself. So because it is true, because people don't, because I have a tendency to speak fast. That, because, so, we all have to understand how we speak to people matters as well.
Thank you, Alice. So Councillor Gittings, sorry,
yeah,
I wasn't
sure.
sure.
Well, we've had two sort of kind of presentation reports where, say, communication does seem to be the key thing, and obviously you're working in similar fields, particularly the stuff as John Ashton has done around maternity, where some of those earlier accounts. I mean, look. I suppose this is really a plea that the Bob ICB actually do listen to you. I'm sorry. Well, I'm not on page 75. Look, I'm 75 on my report. There's a quote from the external consultant of the thing. And look, I'm sure he's a nice chap. He said, Bob ICB is keen to obtain constructive feedback. Well, they don't only want constructive feedback from, quote, service users on their experience of continuing healthcare. Well, isn't that people? I mean, we're people you're accessing. We're not service users. It's terrible terminology. It just doesn't inspire me, that type of sort of approach. And dentistry, the chair, the Bob meeting I went to in Aylesbury, with all very grand place. You actually raised dentistry, and it was a major issue. And actually, we were sitting next to a councillor who was a dentist who'd retired, and his account of what's happening was absolutely shocking. I mean, there was a report on BBC this morning. Where people were pulling their own teeth out. Yeah. This is 21st century Britain, and people haven't got access to a dentist. It's extremely expensive if you can't sign up to National Health, and with the consequence, obviously, people in all sorts of communities. I suspect that people who are struggling are pulling their teeth out and doing their own. So I think it's probably a bit of a focus for this year, and particularly I'm say Reading's, that around Reading to get a network, to get some support in place, because I think health, oral care is really vital, because it leads on to all sorts of other terrible things. Yeah. I'm sorry, but you know what I'm saying.
Yeah, I do. One of the things that just to make you aware that the Health Select Committee, when they met, Health Watch England presented about dentistry, and that's one of the reasons why there's a national conversation taking place. And today there's a lot of stuff coming up about dentistry, but it's all about the commissioning of dentistry. But can I just also say that whenever people reach out to us, we do find a solution for them, because we do reach out to Bob, ICB lead, dental lead, and say, what is the solution for this? So we do that. So my please, if there are people who do feel that that is an issue, reach out rather than moaning about it or stating elsewhere. Reach out to us, and then we can find a solution. Because Melissa knows, but Sarah knows that it is something that's coming up now.
Thank you, Alice. I think we had Alice online first. Does Alice has got a hand up.
Hi, good afternoon. I just wanted to reiterate again about this maternity and mental health, how it's also linked. And we have to have honest conversations about what is happening, and is still happening in the 21st century, even in 2023. This year we put in my other day job, we put in a conference actually for women that have been negatively affected in maternity in Reading, speaking, and it was heartbreaking to hear what is happening. One of the things is that which is included is to contributing to this is help seek access to the barriers of inequalities, especially with the literature being appropriate for people. And also to look at women, the stereotype, the preconceived ideas about women from ethnic minorities are the major things that impact women not to speak out. And exactly like the other Alice said about the hard to reach people. So by the time they come into the hospitals or the maternity side of it, it's like, oh, they're very difficult people to reach. And so they are going to be difficult in the hospital. And so when they cry out about issues, nobody seems to listen to them, and it spirals from one end to the other. And then there are some of them, of course, mortality happens and all that. But when they come out, some are still dealing with the traumas and the mental health. And of course, they can't access mental health again. And so it doesn't stop there only. But I think the most important thing is to look at race is the issue here, and not just talk about anything else, how we actually make sure that we look at everything holistically and look at how these things can affect people and their children and their families and their husbands in future. Thank you.
Thank you, Alice. I think that's really valid points there. Thank you. Sarah?
Thank you. I think just to comment, I absolutely share the views around the terminology that we use in the health service. We should be talking about residents who at times need certain services, not patients, not necessarily service users. It's a very paternalistic terminology that often infantilizes, is that the right word? It belittles the service user and takes away that kind of self-empowerment when we should be talking about residents who need services. So I'm on a mission to try and help change that. And also just to suggest, if it's not already on the work plan for this committee or ACE, maybe we'd want to have a specific focus on maternity services and dental services so that we can get into some of those issues and some of the work that we're all trying to do to improve the offering for our residents. So just to note that.
Thank you, Sarah. I think we'd all agree on the maternity and the dental services, which are being discussed quite a lot at the moment. I agree with that others have said about terminology as well. I work in housing, and quite often people refer to service users, which is just appalling, really. Thank you. Is there anybody else that wanted to speak? Have I missed anybody? No. Okay. Thank you very much. Oh, okay. So I'm not on. I haven't got my laptop. Did you want to speak, John?
John, you put a number of comments in the chat, which most people won't have been able to see because it doesn't appear on the screen. Did you want to say those in person?
Sorry, I was on mute to stop you hearing the dogs. I think we really ought to be exploring with the university about local training of clinical professionals, because they do tend to stay where they've been trained. And most counties now have a medical school. There's going to be more coming along. And I speak from personal experience in terms of what's happened in Cumbria, that they now train their own dentists in Cumbria, linked to Liverpool University, but within the University of Cumbria, because we have very similar problems to what you're experiencing in Berkshire. So I really do think we should be exploring training people locally. And just making that link with domestic violence and the discussion we had earlier on, because very often domestic violence does begin in pregnancy, and staff who are coming into contact with pregnant women are in a very important position for identifying when this is happening and be able to signpost and support women to get help and to leave abusive relationships. And the link across the suicide prevention agenda, because 1 in 3 women who kill themselves has been abused. And then the final point, it's easier to change our own behavior than somebody else's. although domestic violence can be associated with disadvantage, it's by no means exclusively so, and it crosses the social spectrum. There are professionals who abuse their wives, and what we need to do in the health service and the local government is to have a zero tolerance of domestic violence among the women and men as well, there, and have support and signposting and routes out of abusive relationships. There's lots of joining up for us to do here.
Thank you, John. And it's really valid points. Have I missed anybody? No. Okay. Well, thank you very much, Alice, and a really informative and really positive report. So thank you.
Thank you.
So if we move on then to agenda item 7, which is a health and wellbeing strategy quarterly implementation plan, the narrative and dashboard, which is being presented today by Amanda Mike.
Yes, thank you, Chair. So I'm Amanda Nyeke. I'm the Public Health and Wellbeing Manager here at Reading Borough Council. Just a quick update is what I'm going to be providing today on the Berkshire West Health and Wellbeing Strategy. It focuses on 5 priority areas, which are around reducing health disparities, supporting individuals at high risk of poor outcomes, helping families and children in early years, promoting good mental health for children and young people, as well as for adults. The strategy is supplemented by 3-year implementation plans for each priority area. However, we will be conducting annual reviews to ensure that they are still meeting local needs. And we're hoping to be engaging HealthWatch as well in our upcoming meetings, just to make sure that we are listening to what people are saying they need and trying to incorporate that into our action plans. So regarding priority 1, which focuses on reducing health disparities, the Reading Integration Board is working with partners to provide various services and to communicate these services to the at-risk populations. The RIB Board, Reading Integration Board, also proposes projects that are culturally sensitive to ensure that these specific groups are supported. In relation to priority 2, which again is linked to reducing differences in health, efforts are being made to establish a dementia-friendly Reading coordinator post, to develop a joint all ages unpaid carers strategy. There's investment taking place in technology-enabled care, also known as TEC, as well as ongoing multidisciplinary team meetings, which are taking place to help towards improving health outcomes and support people with complex needs and long-term conditions. And then moving on to priority 3, regarding helping families and children in earlier settings. The Under 5s work stream of the One Reading Partnership is leading this effort, and they've been working across various sectors, including maternity services, health visitors, and education, and their focus is on improving access to both universal and targeted health services. Overall, there's been some really wonderful progress that's been made across the areas, but in particular in speech, language, and communication support. And they've also revised a parenting offer, which has been recently established, that also includes new fathers. In relation to priority 4, this priority focuses on mental health and well-being for children and young people. The focus involves addressing inequalities, implementing whole school approaches to improving mental health, providing mental health support teams. There's also work taking place to offer training for professionals as well as parent carers. And generally, Reading has quite a good mental health offer in place for children and young people, which ranges from advice services to specialist interventions. So there's some really positive work happening for children and young people. And then finally, with regards to priority 5, I'll just focus on some of the highlights. This is focusing on mental health for adults. And some of the highlights that have taken place include the annual Mental Health Inequalities Conference, which took place recently, raising awareness and addressing stigma around mental health. It was Mental Health Month in May, and this featured a communications campaign which highlighted the importance of physical activity, the link between debt and anxiety, and crisis support. There's also a number of training initiatives that are in process. They're being delivered, such as the Suicide First Aid Light sessions. These are being implemented alongside some really valuable work, which is almost at completion, which is focusing on developing the mental health needs assessment for adults in Reading. So overall, in relation to the strategy, there is some really positive progress across all of the priority areas, and this involves collaboration between health services, the voluntary sector organizations, community groups, and with the focus of providing comprehensive support as well as addressing the specific needs in the local population. So I'll just give a quick overview of the data and try and just highlight some of the key elements. But I think it's worth noting that this time round, some of the data was coming in quite late, and as a result, we've received some more up-to-date data that is not necessarily reflected in the paper, but I'll try and give a verbal update on that. So regarding priority one, the area I wanted to focus on was the relative risk of cancer in Reading. So when you're comparing it to September 22 and December 22, the relative risk of cancer has increased, which is what we're seeing from the ICS dashboard. In terms of cardiovascular disease and diabetes, the data indicates that this has remained pretty much the same. But the key ones that I also wanted to highlight were around mental health, which is a key point of discussion today in most of the discussions that we've had so far. So mental health and obesity have shown an increase in relative risk, with both being higher than their targets. But again, you know, from the summary I've just given, you can see that there is work taking place to address some of these issues. And similarly to the mental health subject matter, there is a needs assessment taking place around healthy weight in Reading. I also wanted to highlight some positive data as well. There have been significant improvements observed for hypertension, stroke, coronary heart disease, dementia, and learning disabilities with regards to the proportion of people in Reading that have received the recommended health checks within the recommended time period. So we're seeing an improvement in people getting access to those health checks. So I'll move on to priority 2. And again, the data includes indicators that relate to reducing health inequalities and improving outcomes for individuals at high risk. So again, as you can probably see in the paper, a lot of the data that we were currently collating is from national data. And unfortunately, quite a number of those indicators are only updated on an annual basis. So you will note that there haven't been updates on some of the indicators. And we're doing some work currently to start to look at local services that have recently been developed that have been running for a long enough time that they can hopefully provide some meaningful data. So the goal is that we will replace some of the national data that we were using temporarily with more meaningful local data going forward. However, one of the areas that did get an update was around the number of people sleeping rough. And unfortunately, we've seen a slight increase compared to the previous snapshot. So this indicates a challenge in addressing homelessness, and maybe some work that needs to be done to look at that. In terms of priority 3, we've seen an increase in the uptake of trauma-informed training by early years practitioners in the quarter. And this highlights the good work being done by Brighter Futures for Children. And if you look at the table within the report under priority 3, there's some narrative in there just highlighting the great work that's taking place within that area. And then in terms of priority 4, again, just a reminder, this is around mental health and well-being for children and young people. The data has shown a slight increase in the percentage of school-age children with social, emotional, and mental health needs. And this is higher than the national average. However, we've also seen that there's been an increase in referrals to the mental health service team. but in a positive light, we've seen that a high percentage of children and young people that are engaged in this service report moving closer to their goals. And this is quite similar as well with the young people who are accessing the primary mental health team support. And then finally, in priority 5, which is around mental health for adults, generally, when you look at the data, it's quite similar to the previous reported data, so it's remained quite stable. There have been slight changes, but they're not considered significant, statistically significant. But again, just to highlight that I think the data around the drug and alcohol outreach performance is quite varied. So again, we need to look into that in a bit more detail. So overall, the indicators are providing insights into our population in Reading. They're highlighting the areas where further support and intervention may be needed to improve health outcomes. And as I mentioned before, we are working towards looking at what meaningful data we can obtain from newly developed local services so that we can monitor progress against these actions in a more meaningful way going forward. Thank you. Happy to take any questions.
Thank you, Amanda. It's a really helpful and useful report. So lots of information to go through here. I was just going to ask you really quickly, would you be able to expand on some of the indicators with amber ratings? And I'm a little bit worried that I made notes when I've read it and it's been updated since then, because I know you sent a further report, but I think it was around the priority 4, I think it was. Oh no, sorry, priority 5. Just reading my notes. It was about the mental health, the amber. So anything that you can sort of talk about and how on the amber ratings and how things are progressing?
Sure, and I know Martin, it's echoing. I can provide a general explanation with regards to the RAG rating, and I know Martin wanted to jump in and contribute to the response as well. So just to clarify, with regards to the amber rating, the RAG rating, it's primarily for the qualitative data, so it tends to be a little bit subjective. So generally, and apologies if I'm stating the obvious, the way the leads are choosing to RAG rate is dependent on whether a project is completely delivered or an action is completely delivered. If it's amber, there is work actually taking place. So if we look at priority 5, which you've highlighted, and we look at action 6, 7, and 8, for example, you can see that it's been logged as amber, but actually there is a lot of training that is taking place at the moment. But the reason that it's been highlighted as amber is because there are challenges with sustainable resource. And our goal is that we want to put this training in place and for it to be sustainable. And there's work underway towards working towards that, which is why it's still amber. So there's still a lot of action and a lot of work taking place, but we just feel like there's still more to be done. But I'll hand over to Martin, who can hopefully elaborate on some of the other areas.
Thanks, you, Amanda. Yeah, cheers.
I won't elaborate too much, but I think you've captured most of it there. It's about capacity and complexity. You will know that we've faced real challenges in the public health team recently, and having capacity to progress some of the work in this priority area. Happily, we've got some interim recruitment processes concluded for the shared team with Berkshire West, which will free up some of the capacity for myself and the team in Reading. On the issue of complexity, we have made good progress with the network that supports this priority area towards making an application to the Prevention Concordat for better mental health. One of the reasons why this doesn't move very quickly is that it quickly dovetails into what are referred to as the wider determinants of health and the wider determinants of our mental health. If we're wanting to take a primary prevention approach to this, then we've got to tackle some of the bigger wicked issues that are moving slowly. We've got as Amanda said, we've got the mental health needs assessment nearing completion. That's going to inform how we prioritise that. We've also been progressing the suicide prevention work very recently. As colleagues may be aware, we did have a pan-Berkshire suicide prevention strategy, which was being progressed up until March when the person leading that left. So I'm assured that we've got a strategy in place that can be agreed across all the councils across Berkshire. That will enable us to have a platform for our local action plan. And again, Amanda referred to some of the training offer that we've developed there, which we're piloting with colleagues in the call centre in Reading, because they are experiencing a lot of suicidal ideation because of the so-called cost of living crisis. And that has a traumatizing effect on them, and they need to be able to look after themselves and to also effectively signpost people to where they can get the best support for that. So yes, work is progressing, not as quickly and as rapidly as we'd like to, but I hope that provides a little bit more detail under the headlines that Amanda was able to provide.
Thank you, Martin. It's actually really good to hear that the staff are getting the support they need because their work is so vital. So yeah, thank you for that update. Amanda?
Just wanted to add to what Martin said with regards to some of the other areas that are highlighted, Amber. Some of the actions are linked to the outcomes of the needs assessment. So just to clarify as well, until that's done, they will likely remain amber. So just to give you a bit of context there as well. And then finally, we also have a team member that is basically, she's going under training to be accredited to deliver suicide first aid training, and the goal is that she can therefore support others as well. So there's definitely a lot of work underway, and hopefully by the next board meeting we can some of these will be green.
Thank you, Amanda. It's really helpful. I can see a hand up there and I can't see whose it is because I think I need glasses.
Yeah, that's me. That's Cicely.
Oh, hi there, Cicely.
Yeah, to the women that was about healthcare, and did a very reassuring to hear about suicide prevention work continuing or restarting, because of during the COVID, as you heard from the CIPA research, and after, a lot of work went into mental health conversations, to normalize those conversations, and suicide was one of those that was quite not only triggering but also reassuring in the fact that people are beginning to talk more about it. As you heard, this, some of it or most of it is to do with cultural issues or taboo matters, and suicide is one of those that through ACA and other grassroots communities, we've continued to foster those conversations so that people are more aware, but more so to manage the traumas, of the past. So very pleased that that work is beginning and will continue. What I would suggest is that to meaningfully work with the grassroots communities, because you not only get the language, the language to use, but also to work with them in terms of using that language to manage whatever issues are there, especially with regards to traumas. Thank you.
Thank you. Thank you very much. Do we have any other questions or comments? No? Okay, well, thank you very much then, Amanda and Martin. Thank you very much, Lupel. Thank you. So moving on now to agenda item 8, and we have the autism strategy, and it's a year one action plan update.
Sonny's not here.
Oh, he is. Yeah, yeah, I saw him earlier. Hello there, Sonny.
Hi, thank you, Councillor. Yeah, so my update won't take too long. So it seems only recent I actually came to Health and Wellbeing Board to get the strategy formally signed off, which was in January. I think it was January, February. So it was basically just to say, because obviously while the strategy was late being signed off, the Autism Board had an action plan in place and was working to deliver that. So as promised, I said to the board that I would come around summertime each year to give an update on how the action plan had been progressing and generally how things are with the partnership board. So I've just submitted a short report on the high-level updates, and I've also submitted the action plan as part of the appendices, which I won't go through, but I just wanted to give assurances to the board that having the strategy has actually been quite beneficial, I think, because a lot of the partner agencies are actually doing quite a lot of work around autism, and I think what the strategy has enabled us to do was to start to pull all of that work together, and then the partnership board to have a much more detailed discussion about what's going on and how we can make links between the different organisations. So that certainly is progressing quite well. And again, the Autism Partnership Board meets every 8 weeks over 2 months. So all I wanted to do here was just to pull out some of the key developments that partner agencies have done. I'm not going to go through the whole report, but just maybe pull out some of the highlight areas that the Health and Wellbeing Board members might just want to be aware of. So just a bit around training and awareness. Now the Oliver McGann training has been launched. That is now mandatory for all health and care staff, and that is being rolled out via webinars, and that's been received very well. The local authority have a autism awareness course on our training website, and again, all our care providers are asked to complete that. It's a short hour session which gives you overview of what is autism, kind of traits you need to look out for, and the kind of like services that might be available for them. And the other bit around the training is Autism Berkshire. During Autism Awareness Weeks, we're able to have a pop-up shop given to them in the Oracle Shopping Centre. That was allowed for people just walking past to pop in and say, what are you guys up to? And also those who have either autism or have autistic family members are able to go in and get assistance and advice and guidance. And over the week, I think they got up to about 400 people walking in and asking for advice and guidance. So it was a really good week for them to get that done. I'm waiting for a report from them about what was said at kind of highlight areas. So they've promised me to get that in around September time. As for early years support, lots of work happening by our Brighter Futures for Children colleagues, particularly around the early years support. They have advisors at that early age level supporting families in that transition from nursery to primary school and onwards. And where there is people with either autistic needs or SEN needs, they're able to bring in practitioners from both health, social care and education to ensure they have a coordinated care plans moving forward. And that seems to be being received well. Just moving on to employment support. This is an area that is progressing quite well. There's still a lot to do around it, but again, our colleagues in BFFC who have this Elevate team are doing lots of work with the DWP and local employers around developing pathways and accessing employment around for local employers. I think we still have to do a lot of work around probably raising awareness on autism for our local employers, so that is probably an area of work that needs to be done this year and moving forward. Just moving towards work that our ICB colleagues are doing. They're doing lots of work around transition, LD and autism. So they have now a lead really building on this, not just in Reading, but across the Berkshire West footprint. They're doing a piece of work around the pathways, how individuals are tracked across community health, their input into if they go into hospital, and then their transition onwards into adulthood. So social care are feeding into that work, and hopefully they'll have some output later this year. Just moving on to accommodation, supported living accommodation. So our Adult Social Care Commissioning team are at the moment reviewing their supported living framework. And obviously one of the key gaps within that framework is our support for autistic residents and those with challenging behaviours. So they're now engaging with the market, say how can the market change or adapt their specification to meet these bespoke needs, really. They've had some positive feedback. They've gone to the existing providers, understanding what they provide, and then that will inform their commissioning. I think the aim is to have a specification by the end of the year and hopefully go out to tender the next financial year. So that's quite a positive move forward. Lots of work around the criminal justice support system. Again, the police are doing lots of work around this with the support of Berkshire, Autism Berkshire, where they have a lead in the Thames Valley Police, and they're doing proactive, reasonable adjustments in their custody units for people with autism, and also giving training to custody sergeants and so on around adjustments that they need to make if they do bring a person with autistic needs into their custody suites. So that's really positive, and we have distributed autism alert cards to all of the Reading police stations, so that's really good. Last but not least, support for carers and families. So again, our colleagues in Brighter Futures for Children now have an autism advised service. When I say service, it's only a handful of officers, but it's good. They're able to offer support and consultation to families and to advise them on any support that they might need to manoeuvre around children's services and adult services. So I guess what I wanted to just highlight here is that there is actually lots of great work happening out there across the system in this area, and what this allows us to do also is that as more monies might come available, either via externally via central government or via our Better Care Fund, we have this strategy to hang our bids on. And certainly, you know, one of the areas we would want to really focus on over the next couple of years is that employment support. Certainly, that's something that that's been picked up as part of health inequalities and focusing on the economic growth of Reading, really. I think we're very proud of the work that the board are doing, and I particularly wanted to say a well done to Jane Stanford Beale, who, as you know, is the CEO of Autism Berkshire, who I'm sure you might know got an MBE for her contribution to autism and the work around autism in Reading. So that's, you know, it's a positive way forward. So I'm happy to take any questions from the board.
Thank you very much, Sunny. Thank you very much for the update. I know this came earlier in the year, but it was really good to hear all the work that's been going on, and it's really useful. So thank you so much. The training is that you mentioned is absolutely wonderful, and also you were talking about the housing concern. I work in an extra care for working with a different authority, and I'm really well aware of the shortage of accommodation for younger people. I think it's a real issue, so I think that's good. That's been raised too. So thank you very much. And I think we've got some questions. I'm not sure who from. Alice.
Hi, Sunny. It's Alice from Health Watch. Just wanted to find out from you. You know, this card that you were talking about. How many people really know about this card? That I know that Autism Berkshire promoted it last year at Youth in Mind conference, but I think this is something that we could all help to promote more, because I think there are some communities that it's a hidden conversation. So I do think that, you know, this is an opportunity for us now that you've got the strategy to push out that card more, and if we can help to reach out.
That's really great. So yeah, no, I'm certainly happy to touch base with you after, and it might be actually moving forward is having a representative from Healthwatch on the Autism Partnership Board, so you can understand the kind of work and feed that. So yeah, happy to feed back into that.
John,
did
you?
No, thank you. Thanks, Sunny. That's a very nice piece of work and beautifully described in succinct terms. But I think sometimes it's really important to focus in on a specific area like autism. But equally, I sometimes worry that then the attention isn't being given to the wider neurodiversity agenda as well. And I think we have to make that connection somehow and make sure that, all the other folk out there who are suffering do get attention. And I think the employment thing is a kind of entry point, because we're suffering from an acute labour shortage. And what we've seen elsewhere, I mean, I think particularly Singapore, where they've had the problem, has been to really have a big effort on adapting workplaces for people with long-term disabilities of one kind and another, to make it easier for people with disabilities and long-term conditions to work flexibly or part-time. So I think we really need to do a bit of scoping around that as a borough about, this is about making the most of our people and contributing to a vibrant local economy, and at the same time tackling inequality and so on. There's a lot of boxes that can be ticked if we have a proper strategy for this area,
Yeah, I agree with you, John. And I think that's probably, if I was to say where we would want to focus obviously all of these we had 7 priorities, but if I was to say which is a biggie, is that employment one, and that's probably one where I need to work with our New Direction College and see, how do we take this area forward. So yeah, I 100% agree with that one. It might be worth just letting forward though as well. Sorry. Moving forward, one of the other areas that we're doing as part of this year's action plan is how do we, as we start to build the new Hexbox, the new libraries and the leisure centres, is that we're working with a local autistic provider to say how do we ensure that these new buildings are autistic friendly. So we're doing like audits on our newly opened leisure centres and libraries, and ensuring that when we build the new library downstairs in the civic centre, that they are purpose built moving forward. So lots of exciting stuff happening in this area.
Thank you, Sunny. And now it's Paul.
Yeah, thanks, Sonny. And so, as John said, very good and succinct summary of achievements, because this has only just been launched. Actually, it sort of seems like only yesterday we were thumbing through the papers in Labour Group, and now we're a few months in. And you mentioned former councillor Stanford Beale, who was of these parts. You have to leave, and then you get an MBE. But I don't think and all of us will probably not. I was going to say, give a bit of a plug actually for in terms of adult social care. It's really, these strategies really important because, as John has highlighted there, offering employment opportunities for people with neurodiversity and also all disabilities is really important, because if we can get people back into the workplace, obviously the level of support they may require from a council or other outside agency lessens, and for obvious reasons, that's just a good thing. That's a good thing all round. But also we've in tandem with this, we've launched actually at ACE yesterday, earlier in the week, the unpaid carer strategy, and also the adult social care strategy. So I think these 3 strategies working in tandem with the autism strategy will really help to shape our adult social care package and give us more resilience, I think, overall. So I think it's a really important piece of work. I just want to sort of ask you about the identification of people who obviously with autism, because I actually, wearing another hat, go into a lot of schools, and I often come across children clearly who, my son's younger son's autistic, so I've got some knowledge of this, who might look to have some of the symptoms, whatever you call it, of autism, autistic, but we don't seem to be able to identify them, and also in older people as well. So I'm just wondering if the strategy sort of helps to cover off those areas. Identification, I'm not putting it very well, but you know what I'm getting at.
Yeah, no, I totally understand. So I think that there is a significant waiting list for individuals waiting for an assessment to determine whether they've got autism or not. I think for younger people, it's probably I need to check these figures, but I think it's around 3 years and 4 years for adults, so it's significant. And I know the ICB are trying to do lots of work around how they might look to reduce that waiting list significantly. And they have commissioned Autism Berkshire to do some of that pre-work before, while someone is waiting for an assessment. So some of that early intervention work, ways of coping, ways of dealing with it. But yeah, there is that significant waiting list, and the ICB are aware of that and trying to tackle that in other ways.
Yeah, I mean, I think that should be obviously a priority for the ICB, particularly for younger children, but also obviously for older residents. Who, we've seen lots of celebrities suddenly identify. Worked in their 30s. I think Paddy McGuinness's wife suddenly realised she was autistic, and of course this has had a profound impact on people's lives without realising it. So I and certainly from the employment context. So I think that's really important. But I think this is a great piece of work, and hopefully we can have the resources through the ICB funding to really bring so a lot of this to fruition. Because this is about funding, actually, isn't it? About resources. You can have a great strategy unless you've got money in place to implement it. It's a real problem.
Thank you, Paul. I think we've got Graham and then Sarah. So is that right?
Yeah, thanks. I mean, on a church, this is a really impressive amount of stuff done within a really short period of time since the launch. That's great, and it's really pleasing to see. Coming back to, we actually had quite a lot of interesting discussions and debate, didn't we, around the employment area as we're developing the strategy. It was interesting, and that's being reflected back in the discussion today. I mean, one of the things, and as I say, this is not a criticism, because I think this is something that's going to take quite a bit of time, not just the first sort of 6 months or so from the strategy. But one of the things when we're looking at the area of widening out employment opportunities for autistic people, there's a real danger that we end up focusing on what the people themselves ought to be doing and changing and preparing them, when actually to really make headway we're going to have to change the culture of employers and businesses. And I think we discussed about an ambition of engaging in the culture of employers, particularly when we look at it from an economic development point of view, and the real constrictor of economic growth in Reading is likely to be around the labour force and skills in the town. So yeah, I mean, I wonder whether you had any or had thought or any joy with sort of engaging, maybe through our economic development company, the wider business community and partners, in terms of them really, I suppose, addressing their culture, which isn't particularly helpful. So for instance, bringing people into interviews, interview processes can be completely unhelpful when interviewing autistic people. Their skills and potential may not be demonstrated whatsoever through a lot of selection processes, and then the culture of the workplace as well. So yeah, I just wonder whether there's been any thought of that, or how we can approach that.
I mean, I probably, to be honest, we've definitely thought about it, and you and I has had quite a lot of conversation around this in the past. So it's definitely a priority within the strategy. I think where I'm struggling at the moment is to get a lead to really push that area of work forward, and that's probably something I will probably take away and probably have a discussion around our senior leadership group within the local authority to say who do I go to actually push this agenda forward, really, because obviously coming from adult social care, my influence in that area is little limited, so I just need to get that done. But yeah, I accept that. That's why I was saying that I feel that is probably one of the key areas that to drive this strategy forward, really.
To be clear, I wasn't expecting it all to be sorted within 6 months. I'd like to put that.
Yeah, funny. Thank you, Sunny and Sarah. So.
Thank you. I just wanted to come back on a couple of the specific points that I referred to a moment ago. So waits for autism assessments is an area that we are struggling with in terms of long waits. We've been making inroads. So at the moment, only 3% of referrals are waiting for longer than 2 years. 2 years is still a long time. And so we're doing an awful lot of work to try and bring that down. The context is that we've seen an 85% increase in referrals over recent years. That's almost doubling, and it's happened really, really sharply. And there are national workforce shortages in this area as well. So it's an uphill battle, but one that we're absolutely embracing. One other thing that's very pleasing about the autism strategy is the support that is going into people whilst they're waiting for their assessment, because as we know, when someone's diagnosed with autism, there's not sort of a medical treatment plan that you'd adopt. It's more around the sort of the support and the adaptations and the knowledge and understanding of how to live with this neurodiversion. So bringing that support earlier while someone is on a waiting list is really pleasing to see in the work we're doing. And we're also rolling out children and young people mental health support workers into schools. So we don't have full coverage yet across Reading, but we have, and I don't want to quote the wrong stats, but I can follow that up in terms of the coverage we have at the moment. But the ambition is that every school has access to a children and young people mental health support worker to exactly help with that in terms of early identification, and also increasing the understanding of the potential symptoms, particularly in girls and women, that presents very differently to often the case in boys and men, that are probably the more well-known symptoms. So a lot of work going on in this area to try and improve the offer we have for our residents.
Thank you, Sarah. And we have John.
Thanks. I'm just reminded of the fact that there are environmental dimensions that need to be on the table as well. And actually, it's just coincidence that Sarah has popped up from the NHS end. But I've had a recent experience of a hospital environment where they'd provided a quiet room for autistic patients who are waiting in the waiting area, the waiting area for outpatients and so on. So there's a quiet room provided, but it was locked and being used as a storeroom. So, there is this whole issue about accommodating the needs of people with autism who don't like don't cope with the stimulating environment, need to be in a place that's more manageable, that's more under their control. And so that needs to be part of this strategy. And we need to make sure that if we have got facilities like a quiet room in an outpatient department, it's not locked and being used as a storeroom.
Very good point there, John. I agree. Thank you. Thank you very much. Does anybody else want to speak? Well, thank you very much, Sonny, for the updated report. And I would note in the report, so thank you very much for all the work that's gone on so far.
Thank you. Take care. Have a good meeting.
Right. If we move on then to agenda item 9, which is Berkshire West Place-Based Partnership, and it's a briefing from Sarah Webster.
Thank you very much, Chair. I won't talk through the paper line by line. I think it might be helpful just to provide a little bit of high-level context setting first as well. So when we talk about the NHS, generally you can chunk it into those NHS providers of clinical services and those NHS organisations that do more of the strategic planning and funding. And there's been a recent reorganisation in the latter in terms of the strategic commissioning and organisation planning. that's changed the structure of our organisations. So previously we had one clinical commissioning group that covered what we call Berkshire West, which covers Reading, Wokingham and West Berkshire. That merged with the equivalent organisations for Buckinghamshire and Oxfordshire from July last year. And now we are one larger commissioning body that's called the Integrated Care Board. Within that, though, we still retain an important local focus. So my role is to be the director for what was the previous Berkshire West patch, again covering Reading, Wokingham and West Berkshire. And the work that's described in the paper, which is fairly dry governance related paper, so I do apologise, is how we're going to continue to come together as partners within this geography to take forward things that are beneficial for our residents. So ultimately, the paper summarises how we are organising ourselves as a partnership to be able to deliver on some of the areas that are common to the 3 local authority area footprints. So that's where we get the benefit of coming together as a partnership across Berkshire West, where we've got issues, opportunities in common that we can take forward once collectively and can only be done at that level. Whilst continuing to tailor local efforts for things that are unique to Reading or counterparts in for Wokingham and West Berkshire. I suppose the 2 points I'd really want to pull out for this forum is that the health and wellbeing strategy remains sort of the guiding light in the work that we're doing. So the conversations we've had that inform some of those shared priorities are which elements of the health and wellbeing strategy does it make sense to try and tackle together once as a partnership. Also then some of those priority projects are outlined in the paper as well, and I think that's probably the more interesting part, that at a future meeting I can bring a bit more detail on in terms of where we've got to with some of those priority projects. So we've already touched on the inequalities work that I mentioned earlier. That's one of the areas where actually taking a Berkshire West wide approach to the model but then tailoring it for very, very local need is informing the principles of how we're working. And I think I just wanted to also re-emphasise that this Health and Wellbeing Board and equivalents in Wokingham and West Berkshire still remain a really important guiding board in the work that we do as a collective of officers, which really is then the governance structure below this, particularly noting the fact that we have voluntary sector attendance here, we have health watch attendance here, we have councillors who are representatives of our local wards and areas that know our communities very well, and we have communities themselves in terms of members of the public who come here as well. So we very much want to be able to keep working with this forum to effectively hold the work of the Unified Executive Officer Group to account for delivering on behalf of our residents and our local needs. So that was all I wanted to really say on this one, but I'll open if there's any questions at all.
Thank you, Sarah. Did anybody have any comments or questions on the report? No. Okay, thank you. I know we were just noting this report, so thank you very much for the update. So, so if we can move on then to agenda item 10, and again that's Sarah presenting, and it's the Bob ICB Joint Capital Resource Plan.
Thank you very much, Chair. Another highly exciting paper from me as well. So again, I'm not going to go through in detail, but ultimately there's a requirement for the ICB to publish a capital plan each year and share it with the Health and Wellbeing Board. So that's the paper, and the link in the paper provides that information. Ultimately, our ambition is to improve and develop our estate to the best way possible within the financial envelope and funding restrictions that we have and are well versed and well known. You'll see in the paper that this year the capital funding is predominantly going towards maintenance of existing buildings and a level of digital investment as we try and bring our facilities up to an appropriate modern standard from a digital perspective. Complementary to this is there's a lot of work going on to inform our clinical strategies, which ultimately then inform what estates we need to be able to deliver services of the future. Some of the key ones are around our primary care strategy. So what's the strategy for GP practices and other primary care facilities? And also the Royal Berkshire Hospital development as well, and what that may look like in terms of physical estates needs going forwards. So once those strategies are clearer, that clearly becomes an informing point on what our onward capital strategy should be and spending plans going forward from here. And I did also just want to draw out that there's conversations ongoing around how do we draw on the benefits of working as partners, public sector organisations, to maximise the use of existing public estate. How we can kind of more flexibly use each other's estates, where we've got opportunities and need to increase our footprint in one area. Our first ask should be, do any of our public sector partners have some space that we can use, or voluntary sector partners, or how we do it in a more coordinated way to make best use of our public estates. So that's, again, one of our guiding principles at the moment as we take this work forwards. But again, I'll pause there in case there's any specific questions. Thank you.
Councillor Gittings.
Yeah, sorry. I mean, thanks very much, Sarah. And I don't know if the report's sort of out of date or just, in a sense, on page 203, it does mention about the Royal Berkshire has recently been awarded seed funding via the New Hospitals Programme. Well, I thought originally that was going to be one of the 40 new hospitals that was promised by Boris Johnson. As far as I was aware, and sorry, is this updated? Because it says we're awaiting the formal minister announcement relating to associated time frame for guests with the ambition likely for delivery 2028 to 2030. So I'm not certain from this report whether local people know whether the hospital is being rebuilt, revamped, restructured. My other sort of general point is, I think this is really important, actually, buildings and things within the NHS and the capital projects, because actually John Ashton actually circulated a very good article in the Times about the state of the NHS on the 75th birthday. It was a very good piece of work by the Times, where it was saying, well, look, great, look, maybe nice to have 40 new hospitals, but actually we need to actually have less focus on the hospital building and more, you're saying, working with local authorities with primary care settings. So instead of going to some monolith of the hospital and, we invest in primary care, those type of buildings, those community facilities, as part of the Bob strategy, rather than, okay, everybody loves a new hospital, but it's not relevant necessarily to most people's health needs. We want to keep people out of them, actually. And so, sorry, does the capital programme reflect that? And can you update me what we know about Royal Berkshire, if anything?
Yes, of course. So we don't have absolute clarity on the funding available to the Royal Berkshire at the moment for the redevelopment. You're right in that they were announced as one as the, going back, a couple of years now, the 40 odd hospitals that were in the running for additional funding for redevelopment. In the latest announcement, they weren't one of the front runners for that programme. A lot of the funding was diverted to those hospitals that have the, I don't know the technical term, the bad concrete that was, that is an immediate hazard and risk to address. That doesn't mean that the rebuild's not going to be happening locally. There are still conversations ongoing and awaiting final confirmation of when the funding will come through, because it's absolutely acknowledged that the current Royal Berkshire Hospital site here in Reading does need a lot of work. The extent of that and the scale of any redevelopment and those conversations will depend on the funding that comes through. But you're absolutely right in terms of we are having those joined up conversations and need to do this with more focus when we know the kind of the remit of the funding that we'll get, in terms of how do we actually have a look at our clinical pathways in the community with primary care, so that we are in a way building the minimum viable hospital, because the care is being delivered elsewhere, and the hospital needs to be a certain size plus growth, but we've got it right in the community first. So that's absolutely part of the ambition, and colleagues at Royal Berkshire who've spoken here before and no doubt will speak here again would echo that as well. So I hope that answers your question around that.
This is my first meeting. Well, it's actually the second. We had the sort of online thing, just a week or so. Yeah, sorry to ask if obviously been covered before.
No,
it's kind of vital.
It's not. So in terms of the coverage before, it doesn't provide the answers to your question. So it's the same update now. Okay.
Thank you, Sarah. And we've got a question from Rachel.
Yeah, thanks, Sarah. It was just to say, don't forget the voluntary sector in this. And is there a place where we could get involved? It's public space is so precious, and public space where you can do community activity is really sparse, especially in Reading, and it's very difficult to get an even offer of community action across the town. So it would be great to have an opportunity to contribute. It sounds like everyone's desperate for space rather than there being any space going, but the voluntary sector brings volunteers, it can sometimes bring funding, you know, it can bring a little bit of a spirit to a building, you know, if you've got 1 or 2 lone workers or whatever. So please do include us in any discussions that you're having around spaces. So thank you.
Thank you, Rachel. Just earlier this week, we were having conversations around how do we bring the right people together to almost do a stock take of where do we have assets that can be used as a starting point in terms of buildings, meeting rooms, hubs, that sort of thing, and then use that as a starting point for a wider kind of Berkshire West Estates strategy discussion or operational strategy discussion. So I'll absolutely make sure that voluntary sector considerations are included. Thank you.
Thank you. Thanks for the question there, Rachel. And John?
So the problem for me with this discussion is that it normally starts from the wrong end of the telescope. It starts from the hospital end. And I know from talking with Sarah that she understands the need to come at it differently. I think we really need to join up the local authority agenda with the NHS agenda here in relation to not just the full engagement with communities and the voluntary sector to design an integrated system from the bottom up. You know, we need to make sure our housing investment is being made in the right way to support older people living at home longer. And we need to take the pressure out of the system, out of the NHS system, by getting it right at the community end and at the local authority end. And that means that the estates strategy needs to be a joint one that invests in community care, primary care, sheltered housing, extra care housing, grounded in the communities that people have lived their lives in, so that they don't get disrupted as they become frail and elderly and are able to continue to live independently for longer. So I think we need some design principles that aren't based on the NHS deciding what it wants to do and then reaching out to local government to see if it's prepared to go along with it. So I think we're on a journey here. And I really think we've got to recognise that local authorities got some big pieces of the jigsaw, but so the voluntary sector. And I just cast my mind back to the early days and weeks of the pandemic, when it became pretty clear that there was going to be a big burden of care in the community. 90% of healthcare is provided by families, not by the NHS. But there was no effort made in the pandemic to strengthen the ability for people to look after sick and very sick people at home. Baroness Finlay, who's a palliative care consultant in the House of Lords, produced a guide for families caring for dying relatives at home, but it wasn't really widely distributed. And we didn't mobilise the likes of St John and the Red Cross and the Women's Institute and the other institutions of local communities to strengthen community and family nursing skills. So there's a different agenda here, which I hope that perhaps at some point the Board of Health and Wellbeing might like to look at, which is how do you build an integrated health and care system from the bottom up rather than from the top down. So, but I recognise, I mean, Sarah seems to be on the right page, which is a very good start. But I think we need to, you know, take the initiative from the Board of Health and Wellbeing.
Yeah.
Thank you, John. So did you want to respond to that?
Firstly, thanks for the vote of confidence there, John, much appreciated. So I agree, this is the kind of the prevention challenge, isn't it? It's how do we actually move to more kind of preventing people from becoming unwell and having a poorer well-being than they otherwise should do, and do that whilst we're effectively rebuilding the aeroplane while it's still flying. So I agree, it would be very helpful for that to be a consideration of this board as well. We need to give some strategic thinking to that, and through the place partnership we there is an ambition to do that. So yeah, I second the aspirations there from John, and hopefully we can work through it together.
I'm focusing as much on stopping people going into hospital as getting them out.
Yeah, I think we'd all agree with that. Sorry, Councillor Gittings?
Well, I'm just saying, I mean, a health setting can be a local park, can be an allotment. Those are things that local councils have got control of. We just built a fantastic new leisure centre. Nice when the swimming pool's all filled up, but it's good for people to exercise of all ages. But seriously, these are community settings that can be utilised outside of wonderful Royal Berks, which we all love, but it shouldn't necessarily be the priority, which I think John was saying. And if we can do with this board work upwards in around that, we've got Rachel and the voluntary sector here and Health Watch. I think we might sort of get there somewhere. So you know what we're trying to say, but I think it's
Andy?
Yes,
Yeah.
thank you. Andy Czerski, I'm a GP and Vice Chair of the board. I think the work mentioned earlier on about community outreach and trying to demedicalise wellbeing checks, because not everything requires a health check. It's the mental health that was mentioned, wellbeing and general promotion of health and self-care. And using our communities and, as been said, the community assets, whether it's a park, whether it's a local church hall, whether it's a school hall, wherever it is, that's what we need to now harness is what are the facilities available in the community for community outreach workers to work with the residents in those communities. We need to set an ambition of what is the future way we want to reach to our residents, rather than just always saying, "Oh, go to the GP." That's my plea. Thank you.
Yeah, thank you. Thank you for that, Andy. Is there anybody else that wanted to speak on that? No. Okay, well, thank you very much, Sarah. Thank you. Right, okay, so we're moving on to agenda item 11, which is the COVID-19 pandemic update, and Martin White is presenting.
Thank you. I'm just going to share my screen and I'll just breeze through this very quickly. I hope I'm sharing the right screen and everybody can see the slides. Is that okay? Can somebody give me a
It's fine, Martin.
Great. Okay. I'm just going to go through this very briefly. I was asked to bring together a summary of where we're at with the pandemic, which has been the main item on all of our agendas for the last 2 or 3 years. And it's just a reminder that the situation now is that the WHO declared the end of the public health emergency on the 5th of May 2023. There's some data collected on this slide which summarizes the experience so far globally. Sadly, there at the bottom are the number of deaths that were confirmed in the United Kingdom, 226,645 deaths. The surveillance system, as we know, is no longer fully in place as it was throughout the pandemic. But I thought it'd be worth putting in the data sources that we've been using to monitor up to this point. And those lines on the infections increase, the trend lines and the hospital admissions and the deaths show the current position nationally. The current situation in Reading is similar. On the 29th of May, and this is all about the end of May, the number of people receiving a PCR test and positivity in the previous 7 days was 180. So that's 5.6% up from 5% on the 21st of May. So a slight rise there. And on the 31st of May, the uptake of the spring booster was 65%. On the 22nd of May, 4 COVID-19 patients were admitted to hospital at the Royal Berks. And on the 24th of May, there were 18 COVID-19 patients in hospital. 19th of May was the last day on which there was a COVID-19 patient on mechanical ventilation. And sadly, there was 1 death on the 19th of May, but none recorded since. A little update here about the vaccine booster program for 2023. The main point here is the JCVI has advised that there be further booster vaccines for persons at higher risk of serious illness through an autumn booster program later in autumn 2023. That is yet to be announced. I haven't been able to find any more details or information or updates about how that's going to be rolled out at this point. Just a summary, and we've already touched on some of this, some of the comments in the discussions previously about the ongoing concerns. As we know, from the 24th of February, the government removed the last domestic restrictions, and we've moved to the living with COVID phase, which is dependent upon everybody getting vaccinated and adopting the behaviours that reduce the risk of respiratory infection. I've talked about the numbers of deaths. It's also worth noting that there's estimated 2 million cases of self-reported long COVID in the UK. That's 3.1% of the population. So a huge burden left with us there, quite apart from the mental health and other traumas that we've experienced. It's worth remembering also that coronavirus is still a challenge in many areas of the world that are not covered by the vaccine programs, and that the risk of an influenza pandemic remains high. So resources for vaccinations and pandemic control measures need to be maintained and embedded within systems. And this links to the importance of learning the lessons about having a robust health protection function. And happily, we've been able to, as I said earlier, recruit some interim posts to help strengthen and bolster the public health system here in Reading, to learn the lessons about the limitations on housing and the impact on children and young people, population groups who are racially minoritized and suffered a greater burden than everybody else. It's important to maintain the relationships that we have between the council functions, environmental health, emergency planning, trading standards, intelligence, communications, wider partners, and the communities that we linked into to work our way through this. So there's some points to bring that to a close. I hope that's useful and helps a helpful summary of where we're at with the pandemic.
Thank you, Martin. It's really interesting update. It's quite sober reading, really, isn't it? So, obviously, to highlight that COVID is still a risk, and the risk of, as you mentioned, the a flu pandemic. You know, another one is really worrying. The importance of the vaccine, and we need to reiterate that with people that to encourage uptake if there is a booster, an autumn booster. So I'm sure you'll update us if and when that's announced. So
yes,
thank you. It's really interesting reading. So, and I've got a question here from Alice.
Martin, it's Alice. Just to find out from you, do you know how many people are living with long COVID? Do we have data on that?
I don't. On the slide number 6, there's a link to where I found the data. I'd have to drill into it a bit more and reply to you by email if I can. I don't know if I need to reply through the chair, but I've seen several estimates, but they're around the 2 million cases mark.
Okay, it's just trying to figure how it impacts on our services. That's what I'm just looking at, because this is another thing that's hidden and that we need to, because people are living with it and it's got implications with employment and everything. So I think this is something that needs to be highlighted too.
Yeah, I agree. I'll find out more and report back to you.
Yeah, that would be really interesting, actually, because I know it's hard to determine, but yeah, it'd be interesting. Martin, thank you very much. I don't know if anybody else has got any questions on that. It's a really interesting update. No questions, so thank you very much. And that is the final agenda item for the day. And we just need to agree the date of the next meeting, which is noting it, not agreeing it. Get it right? It's the 6th of October. So thank you very much for attending, everybody, and have a lovely evening. Thank you.